Nutrition seems to be coming, Nutrition seems to be becoming more complicated these days. Every day, a new diet or a new food is held up as the cause for or the cure for everything that ails us. We're all hungry for information about nutrition and health, but not all the advice out there is evidence-based. The explosion of nutrition messages is especially confusing for people with chronic diseases. We're bombarded with nutrition advice, and it can be hard to know what to believe and who to trust. There are many new studies that consider the impact of food on kidney disease. Most of the studies we'll review are small, but some of them have intriguing results and warrant further investigation. Brianna will explore some new twists on old dietary approaches and some new research into the role that nutrition may play in the progression of kidney disease. Then I'll share some new ideas about the role of diet once dialysis is started. And finally, Brianna will explain how this information impacts what we tell our patients.
All right, thank you. So I'm going to speak about the role of the dietitian in nephroprotection. I will be covering the topics of acidosis, phosphorus, salt, as well as AGEs. Acidosis is a common complication of CKD, and it leads to CKD progression. One of the reasons acidosis is bad is it is associated with inflammation. 2 small studies showed reduced CKD progression with 2 to 4 grams of sodium bicarbonate a day. Overtreating acidosis is not the answer. There is a U-shaped curve, as both acidosis and alkalosis are associated with increased mortality. So do you think the dietitian has a role to play in acid-base balance? Well, diet does affect acid-base balance, so we do have a big role to play. A high-protein diet results in increased acid load. Studies suggest that reducing protein intake by just 0.2 grams per kilogram may increase bicarbonate, which helps to correct acidosis. Eating more fruits and vegetables may help correct acidosis. This slide shows a list of base-producing fruits and vegetables. These include apples, peaches, zucchini, and eggplant. In fact, one study showed that these base-producing fruits and vegetables are just as effective in improving metabolic acidosis as sodium bicarbonate is in patients with stage 4 chronic kidney disease with hypertension. Addressing phosphorus intake in CKD, even before serum levels begin to rise, may delay disease progression. High phosphorus levels are a strong risk factor for morbidity and mortality in this population. Dietary phosphorus is found in the organic and inorganic form. Organic phosphorus is found in animal proteins and plant sources. The phosphorus found in meats is about 60 to 80% absorbed, whereas phosphorus found in plants is about 50% bioavailable. Protein-rich foods are the main source of phosphorus in our diet. Inorganic phosphorus is used as an additive in foods and accounts for about 30% of phosphorus in our diet. It is mainly found in processed foods, but also added to meat. Almost 100% of additive phosphorus is absorbed. Lower-income patients are at a higher risk of increased phosphorus because of these additives. Cooking methods can reduce phosphorus content. For example, one study showed that boiling and roasting meats, cooking methods where drippings are lost, reduce phosphorus significantly. Pre-soaking in water for an hour before cooking further reduce phosphorus content. Some ways to make this practical for patients include boiling meat before adding it to casseroles, salads, and sandwiches, or soaking meat before roasting. A Cochrane review of sodium intake in CKD suggests that a decrease in salt intake with patients with CKD reduced blood pressure and reduced proteinuria. And as you can see from this slide, limiting dietary sodium requires more than not using a salt shaker. Though dietary sodium shows great promise as a modifiable risk factor for reducing CKD progression, there are some things to consider. Being overzealous with a sodium restriction may compromise a patient's nutritional status, especially in the malnourished. Also, in the general non-renal population, the groups that consumed the lowest and highest amount of sodium had increased cardiovascular and all-cause mortality. This has not been studied in the renal population. The next thing I'll speak about is AGEs, or advanced glycolation end products. Kidneys play a role in maintaining AGE homeostasis. AGEs are bad because they promote oxidative stress and inflammation. AGEs are formed through normal metabolism, but they are also found in food. When kidney functions decline, AGE levels usually increase. Studies suggest that an AGE-restricted diet reduces inflammation. Limiting AGE formation may slow down progression of disease. So what is a low AGE diet? Some foods naturally have more AGEs than other foods. For example, animal proteins or higher fat products are higher in AGEs than fruits, vegetables, whole grains, and milk. AGE formation is accelerated by heat. AGEs are formed when food is cooked with high dry heat, so broiling, searing, frying, and browning. Cooking with low heat and high humidity by boiling, poaching, stewing produces fewer AGEs. Marinating food in an acidic marinade 1 hour before cooking or cooking with a microwave also further reduces AGE formation. Smoking cigarettes results in a higher formation of AGEs in the body. As you can see, the AGE content of 90 grams of hamburger meat varies by cooking method, with boiling being the lowest. Though boiled hamburger doesn't sound the best, it could be used in some dishes. There has been no optimal level of dietary AGEs established, however, less is best. In animal studies, a reduction of dietary AGEs by 50% was associated with reduced levels of oxidative stress. And now I will pass it on to Eileen.
Moving on to dialysis-related nutrition information. Malnutrition inflammation complex syndrome, or protein energy wasting, is very common in kidney disease and is defined as cachexia in slow motion and correlates with poor outcomes, including decreased quality of life, refractory anemia, depression, and higher rates of hospitalization and mortality. The incidence of malnutrition is high in patients with kidney disease, and addressing malnutrition can improve patient outcomes. There are many causes of protein energy wasting, and they include loss of appetite and anorexia that's caused by uremia and taste changes, dietary restrictions due to the renal diet, but also due to poverty, nutrient losses during dialysis and due to frequent blood sampling, hypercatabolism that occurs during dialysis, and due to inflammation, which causes protein breakdown, increases energy needs, and results in lower albumin levels. So I'm going to review 3 areas of research that look at malnutrition by looking at appetite, oxidative stress, and inflammation. Uremic anorexia often begins when GFR falls below 25, and hormones like leptin and ghrelin and some others, which are normally cleared by the kidney, build up and have a negative impact on appetite. Gastrointestinal issues and oral problems also lead to poor diet intake. Missed a page. There are several very large studies that have documented a relationship between reported appetite and nutritional status in maintenance hemodialysis patients. The appetite and diet assessment tool uses the question that you see on the screen to identify patients at risk of malnutrition. These studies show that people with CKD who report that they're moderately to extremely bothered by the lack of appetite are at significantly higher risk of hospitalization and death. Just remember that when your patient tells you they have a good appetite, they still might not be meeting their needs for protein and energy. Many dialysis patients are not quite meeting their protein requirements. Every year, dialysis patients can lose from 1 to 3 kilograms of lean body mass due to catabolism and protein losses during dialysis. This loss of muscle mass translates into the loss of functional tissue. Dialysis patients miss meals because of their treatment schedules, and they often are too tired to shop for or to prepare meals after dialysis. Dr. Kalantar-Zadeh suggests that feeding our patients during hemodialysis will increase albumin and improve quality of life. We have our reasons for not feeding patients during dialysis. I'm not sure that all of them are great reasons, but we don't do it. So there was a recent study where patients were given high-protein drinks in the first hour of dialysis, and the study went on for 6 months. The results showed reduced inflammation biomarkers and improved walking speed, suggesting improved function. And while the researchers concluded that protein intake during dialysis is effective in opposing the catabolic effect of hemodialysis, this doesn't mean that every patient on hemodialysis needs to be drinking a supplement, but there certainly are some patients who would benefit from that. Brianna has also already mentioned oxidative stress. It's the imbalance between the production of free radicals and the ability of the body to counteract them with antioxidants. Free radicals do have a purpose in our bodies. For one, they help to neutralize bacteria during infection, but they're also caused by exposure to cigarette smoke, pollution, and radiation. And importantly for our patients, free radicals are caused by uremia and exposure to dialysis membranes. So we start to look at antioxidants, and selenium is an antioxidant, which interestingly, most hemodialysis patients are deficient of. So the richest known food source of selenium is the Brazil nut. Who knew? There was a study that was done in Brazil where patients were given 1 Brazil nut a day for 3 months, and the results showed improved selenium nutrition, and a follow-up study showed that patients' albumin levels actually increased. But don't count on Brazil nuts to keep the dietitian away. The reasons are that in Canada, as you can see on the slide, Brazil nuts seem to only have about 1/3 as much selenium as did the Brazil nuts that were used in the study. So since Brazil nuts aren't a standard size, we don't actually know what the effective dose is. And if you need to eat 3 or 4 Brazil nuts instead of just the ones suggested in the study, they're also contributing a significant amount of potassium and phosphorus. There's also risk of toxicity after chronic ingestion of just 400 micrograms of selenium a day, which is someplace between 5 and 15 Brazil nuts. And some of our patients, if a little bit is good, they think a lot is better. So another option that is much more promising is pomegranate juice. It's said to have 3 times as high the number of antioxidants, 3 times higher than red wine and green tea. There was a study that was done in Israel where hemodialysis patients were given 100 mils of pomegranate juice in the first hour of dialysis, and the study went on for a year. 100 mils is just over 1/3 of a cup. And in 6 months of this amount of pomegranate juice, they were able to show a significant increase in albumin along with lower infection rates and lower levels of inflammation biomarkers. So why aren't we telling all our patients to drink pomegranate juice? Well, first, I'm not sure that the pomegranate juice that we get in Canada actually has the same activity as the specially sourced and hand-squeezed pomegranate juice that was used in the study in Israel. And secondly, as you can see from this slide, the potassium and carbohydrate content of just 100 mils of pomegranate juice is pretty significant. And for a patient who's at risk of high potassium levels or who has diabetes, that can be a concern. And finally, pomegranate juice, similarly to grapefruit juice, prolongs the metabolism of several medications, which again makes it not a recommendation that we can give to every single patient. Sorry, missed that. You couldn't see from that slide, but now you can see how much potassium there is in pomegranate juice. Several reports have linked high dietary fiber intake with a lower risk of inflammation and mortality in individuals with kidney dysfunction. The possible mechanisms are that dietary fiber increases fecal bacteria mass and thereby promotes nitrogen excretion, which reduces acidosis, and that high fiber foods are sources of antioxidants. The truth is that very few of us actually eat enough fiber. Traditionally, renal diets are low in fiber because they restrict potassium, which limits fruits and vegetables, and they restrict phosphorus, which limits whole grains, nuts, and legumes. And these are all good sources of fiber. On the screen, you can see it is possible on a renal diet to get enough fiber, but you have to choose your foods very carefully. For patients with kidney disease, the presence of uremia promotes the growth of pathogenic bacteria in the intestine, which results in inflammation and reduced immunity. To keep the good and the bad bacteria in balance, you need, to keep the good and the bad in balance, you need both prebiotics, which are the dietary fiber sources that promote the growth of good bacteria and reduce inflammation. And in some cases, you also need probiotics. For example, for people who are on antibiotic therapy and for some cases of chronic diarrhea, probiotics can be very useful. You do have to be careful, though. For some patients who are immune compromised, probiotics may not be your best choice. There was a study that was done in Mexico where hemodialysis patients were given quite a low dose of fiber and a low dose of probiotic daily for 2 months, and they were able to show reduced gastrointestinal symptoms and a trend to reduced inflammation. The scientific knowledge in the area of pre- and probiotics and how they relate to kidney disease is expanding rapidly, and I think that it probably warrants a presentation of its own. The renal diet is arguably one of the most restrictive diets there is. The task of finding anything to eat is a major challenge for many of our patients. So Brianna is going to explain how we frame some of this new information for our patients.
All right. So patients, I guess you can't release it. Patients are often very frustrated when it comes to potassium. They say, why is it high? I don't eat any high potassium foods. Limiting potassium limits fruits and vegetables, which are cardioprotective, have antioxidants, are base-forming, and contain vitamins and minerals. So what should a patient do? They should be familiar with and avoid foods that are very high in potassium, eating more low to moderate foods as available, maybe even a small glass of pomegranate juice. In some cases, use of potassium binders may allow patients to eat more fruits and vegetables with less risk of hyperkalemia. And finally, food preparation methods. Like with phosphorus, boiling and soaking foods can reduce potassium content as long as the water is strained. Protein is a real balancing act for our patients. It's a balance between management of kidney disease progression and preventing malnutrition. While some literature recommends a lower protein diet to delay progression of disease, the risk of malnutrition in renal patients is too high for this to be the main focus. Dietary strategies to promote good protein intake without causing high phosphorus intake, acidosis, and AGE formation include selecting foods with lower phosphorus to protein ratio. For example, egg whites. Egg whites are a good source of protein and low in phosphorus. Substituting egg whites for the meat at 1 meal a day decreases phosphorus but maintains protein intake. Avoiding phosphorus additives. As mentioned before, phosphorus additives are 100% absorbed. This means reading the ingredient list. Boiling food may be suggested to reduce phosphorus, AGE formation, and potassium. And for the dialysis patient, it's important to eat enough protein, especially around the time of their treatment. So how much protein should a patient eat? Clinical judgment is used to assess protein needs when there are additional needs like wound healing and surgery. But generally, the amount that's recommended for protein with people with CKD is the same as it is for a healthy adult. That's 0.8 to 1 grams per kilogram, with 60 to 70% being from high biological protein sources, so that being meat, fish, and dairy. For many, this can feel like a restriction, but the low-protein diet is just not true. While there are some patients with CKD who eat more protein than what is recommended and for good health and need to cut back, many frail patients do not eat enough protein, so we work with them to increase high-quality protein intake. People treated with dialysis do need more protein, about 1.2 to 1.4 grams per kilogram. And on this slide, you can see how it translates into food. With all this information about nephroprotection, appetite, antioxidants, as well as fiber and probiotics, the question is, how can we tailor the diet message to meet patients' individual needs? The dietitian's job is to make the complex simple by providing with each person with specific take-home messages tailored to their situation. First, we try not to overwhelm our patients. Instead, we pick 1 or 2 main things to talk about. We have to be realistic with what each of our patients can do. Second, we work with patients to eat more fruits and vegetables and high-fiber foods. within their potassium and phosphorus allowance. Benefits may include reducing metabolic acidosis, increasing prebiotics, and antioxidant intake. And finally, we encourage patients to eat fresh, unprocessed foods and provide recipes that reduce phosphorus, salt, and potassium. Though it will be unrealistic to expect a patient who loves to barbecue to boil their steaks, we would focus on monitoring the portion size of meat, choosing products with no phosphorus added, and suggest using an acidic marinade to cut down on AGE. We hope that we increased your current knowledge about diet treatments for people with kidney disease and had the opportunity to learn how the renal dietitians tailor messages to meet patients' needs. If you'd like to do some more reading, the following slides, which will be available online after the conference, provide our references. Thank you.
Thank you both for that enlightening talk. It's pretty overwhelming, isn't it, when you think about this advice being given to patients on top of their medications, their regimens, everything. Any questions from any audience members? Perfect. Dr. Carson.
I'm wondering if you know about any evidence for giving potassium binders. Are there any studies of looking at antioxidant levels or outcomes in terms of allowing patients to liberalize their intake of those really healthy fruits and vegetables?
Well, the studies that we were able to look at, certainly when they're provided with higher intakes of antioxidants, which you would get from fruits and vegetables, absolutely reduces inflammation and oxidative stress, and so you do see increases in their albumin levels. I very pointedly didn't say that our patients have low albumin levels and that low albumin levels are related to mortality, because low albumin levels are more related to inflammation than they are to nutritional intake in many situations. Certainly getting enough protein in the diet and calories in the diet is important, but often that's overridden by inflammation. So I think that whatever we can do to try to impact inflammatory changes is really important. And certainly, again, they're small studies, they're N of 20, but they did show that people were gaining having higher albumins, which is certainly positive, and having more function as a result of that.
What about actually using K-oxalate over, are there any trials of K-oxalate?
I don't think so. That was Kalantar-Zadeh's suggestion that one do that. What I do know about sodium bicarbonate, and I don't know if it relates to K-oxalate, is that sodium chloride, the sodium is more absorbed and causes more plasma volume increase than it does from the sodium that comes from a non-chloride salt. So there may be less concern about using different forms of sodium.
Any other questions? I think one comment I wanted to make was, the idea of having this audience, if you will, when people are on dialysis, and being able to feed them there. It's an intriguing concept. Some literature shows this improved functional state, fewer biomarkers. The idea of a small amount of pomegranate juice is worthwhile. Maybe there's some other magic compound. There were a little bit of discussion in the front rows here from us nephrologists about concern about maybe overfeeding and getting low blood pressure. We've all seen that. Tell our patients to eat small meals, so maybe there's a sweet spot we can look at.
I just want to add, because I'm very old, and when I started in dialysis, we fed our patients. They all got meal trays, inpatients and outpatients, and as time went on, not for a clinical or a medical reason, but because of cost restraints, we started giving them bagged lunches, and then we eventually gave them nothing. And so as much as we say we're doing the no meals for all the good reasons of improving clearances and reducing hypotension and not giving nurses duties that are not within their scope, and infection control of all of that. I know in other parts of the world, they feed people during dialysis and they don't have a lot of adverse effects.
I think just one more question then.
I'd love to feed the dialysis patients a meal on dialysis, so breakfast, lunch, and dinner. I think that would be a great thing. But that's aside, because I don't know who'd pay for it at this point in time, and who'd clean it up. But in terms of potassium, I struggle with that as their GFR drops. I always struggle with how much to liberalize their diet so that they can have the fruits and vegetables and take away the ACE inhibitor, and the relative benefit of an ACE inhibitor in this population at that level of renal function as compared to being able to eat fruits and vegetables in their diet. And I tolerate a high potassium in my patients. I'm happy as long as they're less than 6. If they're 5.9 and they're sitting stable, I leave them alone. So, and I tell my dietitians to leave them alone too in terms of restricting their potassium further. I don't know if my...
Are you talking about patients on dialysis or CKD?
I'm talking about CKD patients.
So usually you don't see the rise in potassium until they're at least stage 3. So maybe if we can feed them lots of fruits and vegetables before that, they won't progress as quickly. But then you have to manage medical concerns. But there are lots of, it brings me to a wonderful point. There are lots of fruits and vegetables that provide antioxidants but not as much potassium. And the Renal Practice Group has just, with the support of the BC Renal Agency, released a new revision of the potassium diet sheet. So there's 2 forms. There's a basic and an advanced, and the advanced includes fiber information on all of the foods that are listed in the low, medium, high range. So people can make better choices, and we're just about to release another information sheet on fiber and the renal diet. So those will be good resources.